very tricky part of the sexuality which we all are not very aware how to deal with it, and today sir I welcome you sir and thank you for being here and to empower us on this important topic. Over to you sir.
Thank you for those wonderful words, ma'am. And it's an honor to share the stage with stalwarts of IIT and stalwarts who have been speaking about sexuality. I was as confused as a few of you would be when talks about gender started. And despite having come from one of the best medical colleges, Army Forces Medical College, Pune, and having 3 decades of medicine under my belt, training in pediatrics, management, sonology, I was still confused because I was brought up in a binary world. I was taught right from the time I entered medical college that there are 2 human forms, male, female, and sex equals gender. Quickly. And I was also told that this is normal and this is abnormal. And look, here today I am sharing the stage with stalwarts to talk about gender and sexuality. And I am going to be, I modified the topic that I was given. So I will speak about development. Because development is what we pediatricians understand. And I will also talk about gender affirmative care in both children and adults. Disclosures, none. And these are the references that from where my talk comes out, and I would read these slides over here. Please go through these references. What's written right below is personal communication of lived-in experience of people with gender incongruence, and that is the library from where I have picked up the most. And I would implore you as leaders, because I consider pediatrics to be one of the best specialties in medicine, because we look at the seed, and it is we who nurture this seed to become the human resource that is going to shape our society. Yes, we will talk about the what, why, and how of gender and sexuality, gender incongruence, and gender dysphoria. But let's begin from where it all starts, and when this human form, at the age when we think that they understand the different forms that are around, they start looking at people around them and try to identify as to who do I fit in with. And in this, they are cued by the adults around. The pink blankets, the Barbie dolls, the guns, these are all cues which are given to this human form who is trying to find out that who am I? Who do I belong to? And we assign a label which says that yes, you identify with this human form because I have seen what is between your legs. And yes, it is anatomy which tells me what is my assigned sex. Gender, however, is something which is my personal perception, which arises out of the neural connections that my brain is making as it is developing, aided by the biochemical milieu in which these connections are forming, guided by the DNA that I inherit, molded by what is given to me by society. So yes, there is a genetic code, there is epigenetics, there is hormonal milieu which is influencing the neuroconnections which are forming, and gender arises as a perception out of all this as unique as a thumbprint. However, the label that I am being cued to, I look at this and I say, okay, I can probably fit into one of the binaries that is being exhibited to me, and let me experiment with this label that is given. This experimentation happens in pretend play, and it happens as early as 2 years of age, which we know now of, which is scientifically proven, that children as young as 2 years of age know what they feel inside. They are still, or they may still be experimenting to find out who they fit in with. And this period is called gender fluidity. However, I may, right at the word go, align with what is being presented to me, and then I am agreeable with the label that is given. So by 2 to 5 years of age, about 95% of us are okay with the sex assigned to us and our gender that we affirm ourselves. There is no incongruence in that. No congruence. But then all of you know the normal distribution of stuff, and we are the 2ST of that normal distribution who affirm to the binary. But then the 3ST, the 4ST, the 5ST, who are at the periphery of this normal distribution, not abnormal, normal human forms also exist, and they define what they would identify as, and that is what is known as gender identity, and this happens in preschool. What I identify with, I express. So I express in what I play with, how I dress myself, my mannerisms, my interactions. So this is my gender expression. However, expressions can be confusing and do not need to be taken at face value. Because today, I may want to express more of my feminine side. Tomorrow, I may want to express more of my masculine side. But today, what I present to you, you need to accept that. And if you do that, then I am comfortable. As the child grows and crosses standard 2, enters puberty, and puberty is such a difficult time, we get face to face with emotions and attractions which are very different from what we had when we were pre-pubescent. And these are attractions of the heart or sexual attractions, and this defines our orientation. And again, that normal curve appears where 2ST of us would probably get oriented towards one human form more often than others who are 3ST, 4ST and 5ST. But then, statistics tell us that up to 11 to 14% of children in the age group of the beginning of puberty will have differences in sexual orientation. So, heteronormative state is actually not 100%. And not being heteronormative is not abnormal. If I am a child and my affirmed gender does not match the assigned sex that is given to me by society around me, family around me, peer groups around me, then I become uncomfortable. And I understand that I am different. This is known as gender incongruence. And there is a fear of non-acceptance. If this fear of non-acceptance is there, then I do not exhibit. I go into a closet. And this closet may happen in preschool, when my school teachers tell me, sit with the boys, sit with the girls, and I am wondering that I don't identify with either of these. Where do I go? Or can happen in the family and society where I do not agree to the cues that are given. Or it may happen when I am going through my phase of growing up and trying to identify with my peer group. This closeting can happen at various levels. If it is gender, it may happen very early. If there is added confusion about orientation, then I end up in a double closet. In this closet, it's a very dangerous space, especially now, when the children are connected to the world. And it enhances the incongruence that I have, leading to more internal conflict. This, added to non-acceptance and non-resolution, coupled with external conflict, produces dysphoria. And this dysphoria is what we call as gender dysphoria, a very high risk situation. Because what I am becoming uncomfortable with is the non-acceptance of my narratives by my near and dear ones. I no longer believe them. So people who are supposed to moderate my behavior are out of my purview. I am talking to other people in the closet, and so starts high-risk behavior. What may be an innocent experimentation in another child would be unmoderated in me. The frustration would lead to self-harm, substance abuse, mental health issues, further on lifestyle disorders, unmonitored behavior, sexually transmitted illnesses, and decreased life expectancy. You will be horrified to know that there are studies which say that children with incongruence rarely cross the 4th decade. Yes, you heard me right, 4th decade. And why so? Because of dysphoria which is created by us. Hence the action point here is this dysphoria. The intervention points also come in, and I have purposely got them here for you to understand with development, because this is how the psychosexual development of the child is happening from as early as -2 years to onwards to plus 18, and sometimes even further, because adolescence is an age which has a beginning point at standard 2, not clear as far as ages go, and an end point when I am able to make decisions and also understand the consequences and be able to stand by them. So this in our country may be shifting to maybe 22, 23. We still have people who are not able to make these decisions, so we cannot probably say that they are really adult in their behavior. The first intervention point, and this is where gender affirmative care comes in, is to stop the internal conflict by agreeing to the narrative. The second and more common intervention point, which is done by most of us, is to prevent this high-risk behavior, which we may do through disciplining or rules or coercion, but none of this works, because a person who's incongruent and dysphoric will carry on in this line. We may reduce external conflict by talking to parents, talking to teachers, and reducing the external conflict. But will we mitigate dysphoria? Yes. Mitigate? Yes. Prevent? 90% yes, but not 100%. Because the perception has got so many factors which are adding to this incongruence. We will modify lifestyle disorders by creating role models. We may increase the life expectancy by making provisions for healthcare, and that is where your knowledge of transgender healthcare will help you. We also need to talk to family and society, and that is where we require governments to come. We require societies to become aware of transgender health. We need to prevent this fear of non-acceptance. We need to prevent closeting. We need to understand gender identity. We need to learn this new language, unlearn the binary one that we know of. Know this trajectory of development, psychosexual development, gender development, which I am sure none of us read in that chapter which is there in Nelson. And as the editions of Nelson increase, the volume of that chapter increases, but unfortunately there's never a question from there, so we never read about it. Only maybe talk about it if we ourselves are faced with somebody who's encountered it. And here is where affirmative care comes in. And the most important thing is to accept the narrative and rebuild trust. Then he is going to move to the trust. As if this was not enough, we also have other things which get added, and these are social, where we talk about intersectionality, and it may be coming from mental health issues, language, political affiliations, religion, name it, and there are so many of them. I also want to tell you about what is the Indian scenario, because as pediatricians, when we sit on our clinics, we cannot be divorced from what is happening outside us, what the government is doing, what are the facts. So this is the population of India, 1/5 of the world population, and hence 1/5 of the population of diverse individuals. And even if we take the prevalence to be as low as 1%, actually the prevalence is 2 to 4% documented. But even if we say it's 1%, then we are talking about a very large number of children who are not under the radar of healthcare providers, because these children don't trust you. These children are shy to talk to you because you yourself are very uncomfortable talking about gender and sexuality. Hence, it was not surprising that in 2011, when we started to count people, we were only able to count a little less than 5 lakh people. So where are these people? Most of the people who gender encounters are closeted and living with families. They are invisible. A very high risk situation, because they are invisible to the family. Family doesn't have no idea because the child is not sure with the family. They are invisible to the healthcare providers, to the social structure that is there. Very few of these children find courage to talk to their parents. And very few of the parents accept the narrative. And the situation improves. They become visible. Some of the things that I showed you in the development, they reduce. The child is trusting, so maybe a little less high-risk behavior. Monitoring comes in. So this go on. But not all are lucky. The large percentage, the families are abusive. Because the parents are very bachara people. They are looking at relatives. They are looking at what this child will do outside. This child will not be able to get a job. This child is going to get killed. This child is going to ruin my family name. Hence this child, after he's come out and found that the world is not kind, decides to run away, moves out. No community support. Visibly invisible, you see them on the streets, but they are at very high risk. They are visibly invisible to healthcare providers, to society, to you and me who roll up our windows. a small percentage of this start living in stealth because they realize that if they are to express their true self, they would probably not be able to survive. So they become again invisible and a very high risk situation. Some of them, they find community, and the communities that we know are the Hijra, the Kinners, the Joktas, who welcome them into their fold, but there is a price. You have to follow their traditions, you have to follow their methods of earning, and they become high risk for sexually transmitted illnesses, lifestyle disorders, and these were the people who came under the target of NAPO, right? And they became visible to the government. 96.5% of transgender persons in India are invisible to healthcare providers. And you'd be, I'm sure you'll not be surprised because all of you here would say, I've never seen a gender incongruent child in my practice. No parent brought your child to me. I know ambiguous genitalia, but nobody said gender. And then I've been operating. We have people who say, "Batao, kaise raise karna hai?" I say, raise it like a male or raise it like a female because this is easier to do, and maybe that will lead to more complications. What gender? What sexuality? So pre-2014, and 2014 is a landmark year because there we had the NASA judgment which gave the right for self-affirmation of gender. And this is the year where the transgender, third gender word came into the vocabulary of Indians. However, majority view gender incongruence as a disorder. There were no Indian standards of care, no regulations, no accountability. There were a few people who would, take advantage of this very lucrative segment, who were ready to do anything to pass as what they affirmed. There was lack of organized transgender healthcare delivery structure. Because public system, you never saw transgender people. You were so busy treating diarrheas and URTIs, and who has the time for gender incongruence? Lack of empowerment. So misinformation. And gatekeeping by the providers. By gatekeeping, it means that the mental health provider who's sitting in the private practice, if he sees gender incongruent person, he would try to keep them in their practice. Endocrinologists would talk about endocrine support, keep them in their practice. The reconstructive surgeons would say, okay, get the money, I'll get you operated, and then they disappear. Very high cost of treatments. So most of them would save money, go to Thailand, probably get some surgeries done, and die here in India because there's no post-op follow-up care that is there. No medical insurance. So post 2014, the community got together and the healthcare providers who were aware started a strategy. And the strategy was to do a multi-pronged approach, partner with the government, talk about holistic care, shift the lens from HIV, have a public health approach, work on these 4 pillars, and with knowledge, we picked up on the only standards of care which were available in the world, which was the World Professional Association for Transgender Health, WPATH, which had written the Standards of Care version 7, and we put out Indian Standards of Care version 1 in 2020. Today, as I speak to you, we have the Standards of Care version 8, which was released on 16 September 2022, and I will be sharing the outcomes of that with you. So this is knowledge that we thought that we must pass on to people. You'll be surprised to know that we were able to get the government to listen, and thanks to NAPO, which started working with the Ministry of Health. And this is important for this August gathering to know that what is the current atmosphere in the health ministry, where we are asking for a center of excellence to come up in Delhi. The nodal officer is none other than Dr. Manish Singh, who is the HOD reconstructive surgery, and very soon we will be having a center of excellence where we will be teaching transgender health, and we will be setting the template for delivery of transgender health care. We have approached the National Medical Council to look at the medical curriculum and introduce transgender health as a subject. Because just imagine the young medical graduate, if he is going to move into medical education thinking that there are only forms, then there is going to be an issue. But if right from the word go, gender education is given, then things will improve. We have also got in touch with ICMR, and we are now taking up research with them. We are continuing medical education, IAC activities, and I thank the organizers for inviting me here to share this information with you. So the second pillar is healthcare, and healthcare needs to be delivered in a systematic manner, because when we are talking about incongruent people, and I'm sure you all remember the complex figure that I showed you earlier, we require everything under one roof. We cannot have a person who has gender dysphoria who is unable to talk to people, to travel from one OPD to another. Because he may land up with a mental health champ, but he will disappear. He may go to the endocrine person and he says, get some lab tests done, and then he finds a person who's not friendly. He will disappear. So we require gender-affirmative care centers to come up, and again, thanks to the government, we are going to have 35 such centers all over the country. The first is going to be there in All India Medical Institute. We are hoping that each medical college has a department of transgender care. We are also simultaneously getting the community to get the transgender healthcare centers that they are operating at the community level to cook. So with the center of excellence at the center, the community run healthcare facilities at the periphery, and these gender affirmative care centers again run through the government agencies. In each state, we will have a web of healthcare facilities, a modified hub and spoke method. We have empowered people. We had the NASA judgment coming out in 2014. In 2017, we had the reading down of Section 377, which criminalized same-sex relationships. We have now a Transgender Persons Protection of Rights Act. This is an act of the Parliament, and it governs you. It directs how you need to practice your medicine, because it is here directed that you make provisions for giving gender care. It is also directed all medical personnel to continue to gain up and come to understand what is the medical evidence now. The Transgender Persons Protection of Rights Rules has come out in 2020, and it allows a transgender person to self-affirm their gender and also change their gender markers in all official documents. So be it your mark sheet, birth certificate, death certificate, marriage certificate, inheritance, it is all made possible. They also had a change in the national education policy, where dropouts from school are being prevented. And though the bureaucrats could not understand the whole spectrum, but they were aware that there are a large number of trans feminine people, and hence they have clubbed them with the girl child. And the government has put its money behind the words that they utter by allotting funds. And all schools have been directed to ensure that no girl child or any person with gender diversity, including sexual orientation, gets bullied or has to leave school. This is what is written in the Act, and NACO has already covered the first part. We have covered this part where we have given the government a manual of standards. But these are not perfect because they need inputs from you. You need to look at these and modify them. The Ministry of Health and the Ministry of Social Justice are working together. They have put out a SMILE scheme wherein now medical insurance is being given. And the Ministry of Health has entered into an MOU with the Ministry of Social Justice, and there is a cashless medical insurance of up to rupees 5 lakhs per year, which is given to transgender people for care. The only issue is that we do not have the trained people who will be there to provide this care, and hence it becomes so important that we look at what is the medical evidence and learn. This is the national portal that has come up, and herein it is not only talking about gender identity, it is also talking about certifications, medical schemes, social schemes, housing, jobs. So with this background, I hope it's not going to be heavy for you. Let me come to affirmative interventions. And you would have understood by now that it is multidisciplinary, multi-speciality. We are looking at individuals because these are not patients, these are not abnormal people. They are coming into your facility to gain from what you have learned or what scientific advances you have made. They are looking for care and not cure. Why this should be done? Very simple. To allow people to be their true self, prevent dysphoria, and also prevent suicides, prevent mental health, drug abuse, trafficking, etc. Who needs this care? The individual. That means the child, the adolescent, who is gender diverse. He is the one whose narrative we have to understand and tell this individual what we can provide. And when do we do this? At the earliest. And the earliest, when the child is going to step out or open the closet a wee bit, is when the body starts deserting the child. When what he imagines in pretend play will no longer work. And that is Tanner 2. And who can advise? Well, the pediatricians need to take charge. We need to start looking at children and not merely boys and girls. And we need to understand that there are diverse human forms. We need to have a gender-affirmative care team where we need all these people. We need the individual at the center and the pediatrician as the leader. We also need social support. And we need parent support groups. And we need a legal and ethics team. Because you are entering the territory which may not agree with your sensibilities. Because you have been brought up in a different way, and you may approach this individual with your baggage. And this is the worst thing that can happen to the individual. And this is where education plays such a role. So, multidisciplinary teamwork, mental health, endocrine care, surgical care, preventive care, aftercare, all together, primary, secondary, tertiary care, all together. Understand the co-occurring issues. These are not barriers for care. You need to understand them and then work with them so that we can help the child align their gender. We are not changing the gender. We cannot change the gender. The gender is hardwired. But we can change the body. And we can do this by making them comfortable at a psychological level, at a physiological level by cross-hormone therapy, by giving surgical intervention, at social level. We also must remember that we are talking to children and they may not have fertility, they may not have parenting, they may not have companionship as the first things that they are thinking about. and it is up to the pediatrician to flag these before they get into interventions. And where does this happen? Well, it has to happen here. And we need to have a legal and ethical team here. Interventions for children, and in children, we only do interventions if dysphoria is increasing. Otherwise, we accept the narrative and give a nurturing environment. What can be done is puberty blockers, and my pediatric endocrinology friends have been using puberty blockers for ages, and they are very safe, provided you know how to give them and you understand how to monitor them. And hearing is another indication where puberty blockers come. And cross hormones at a case-to-case basis, because legally we want the individual to understand the import of the decisions they make. So cross hormones are generally given after 16 to 18 or whenever we have the adolescent who shows adult behavior. Why give puberty blockers when our aim is to prevent dysphoria? Because if we prevent dysphoria, then we will have a child who will be productive for society. And it helps us buy time. It is an irreversible situation. We give puberty blockers for only about 2 years. And in these 2 years, we buy time. We prepare for further interventions. Cross hormones. So, we require the cross hormones to be given before any surgical intervention is done, because that will allow the body to mold naturally. And we need at least 2 years. So, again, surgical interventions, you require the person to be an adult. And when I say adult, I'm not talking about age. I'm talking about the adult way of thinking. So, more than 16, 18, because now those ages have been, the barriers of ages have been removed. It is you who is to understand as to who can be given these interventions. You need to define realistic goals. A person who is a child has something that they are imagining, and we have to tell them what we can do. There are non-medical processes which can help make this process simple, again help us buy time, and they are listed here. But what about voice therapy? Because voice is something which is so unique. It's a method of when we communicate and we use it, right? And it also gives way what our gender is. It is unique to us. And it is diverse. A lot of people tell me, you have a feminine voice. I get this, madam, your order is here. And I have to tell them, okay, lay out in a slightly gruff voice. But just imagine if we do a little voice modulation for these children, then it will help them affirm their gender and decrease dysphoria. For surgeries, like I said, these are the criteria. For pediatricians, I don't want you to know these by heart, but I want you to know what are the surgeries that are available, because so that you can answer questions. The issue is that the person should believe that the pediatrician knows everything. So these are the list of surgeries which are feminization, these are masculinization surgeries. These are issues which you need to know and be ready to provide in an age-appropriate method. And I'm thankful to Sir for taking such a difficult topic just before me, where we are addressing these issues in an age-appropriate manner. We also need to be talking about parenting, and we also need to be reading about these apps so that we are aware. Preventive healthcare is also something that we need to know. We need to know that this is lifelong care. So yes, this is, I think, something that you would all be waiting for. Sir, do I have about 5 minutes more to go ahead? Yeah, okay, thank you so much, sir. So, this is the latest standards of care, and these were released on 16th September 2022. And you'll be glad to know that we are also having international conference in Delhi on the 28th and 29th of October, right across where we're going to be having speakers speak about these very standards of care. So if you have any doubts, please come over. So what are the recommendations? The standards of care for the first time say that the adolescent needs to be handled slightly different from children. And I began my talk, I said that we look at the seed. The adolescent is the trunk and the adults are the branches. So right now I have an opportunity to be speaking from the trunk point. So I will talk about the adolescent recommendations first. And the recommendations talk about who is qualified. Talks about please give care if you are licensed. Talks about give care if you are trained. This is what these 5 points talk about. It is only if you know, then you come into this field, because this is not something that you can set up in an independent clinical practice with a stethoscope. You need to have the gender affirmative care team. If not physically in your center, at least on your laptop, on your mobile, in your contact list, in your friend circle, so that you can consult and help the child make the right decisions. Training and expertise. Expertise cannot come without training. Expertise cannot come till you do not start opening your eyes and looking for these children. Because when I have ambiguous genitalia in my neonatology unit, I need to be aware that this ambiguous genitalia also has a gender. I need to pass this information to the primary care provider, the general pediatrician who is going to be handling. I need to involve the endocrine people and tell them that, good, this doesn't have CAH, but then there may be a micropenis, or they may be undescended testes, and let's start talking. Right? And we also start talking to the surgeon, because we don't require you now. Please don't do anything. Don't give this choice to families, ki ladka banao, ki ladki banao. Let them be at an age when they can define their gender, and that is when we will call you. If it is life-threatening, then by all means do a surgery. But remember, leave tissue so that we can do modifications later. Be a good surgeon and not a butcher. Again, we have trainings which are being talked about, and we want, the recommendations are that all pediatricians should at least go and read that chapter in Nelson and know about development, so that they can thread developmental pediatrics to adolescent care and then onwards to adult care. They need to know about the child's mental health and also the family's mental health. It's so important. There is a large number of children, and this we are now finding out, that neurodiversity is the norm. But neurotypical response is 2SD. So I may be neurodiverse, but my responses may be typical, and hence I may not fit into the autistic spectrum disorders as has been taught to us. When I entered medical school, there were a lot of work going on in autism, and we were also talking about people swimming with whales as a cure for autism. We have matured to now know that there is much more. And what is interesting is that if the child is not able to communicate to you in the language that you know, then you will misgender. Hence, you need to get trained. Continuing education is again and again access and integrate the knowledge. Get the widen your vision. Look at epigenetics. Look at social structures. Because gender in India is different from gender in the West. There are two you need to consult, and that is again a recommendation. We need to work with others, and this is one area where I find that intelligent people face the greatest difficulty.